Good afternoon and welcome to everybody to this month's Share and Learn webinar. Before we start, I'd just like to mention that we do have a diverse audience for these Share and Learn webinars, and therefore we would appreciate everyone being respectful of any contributions from participants and wherever possible avoid using jargon. Okay, I'd like to firstly introduce Anne Webster, who's the clinical lead from the Learning Disability Programme in NHS England. Gavin Harding is the Learning Disability Advisor for the Learning Disability Programme in NHS England, and also Maggie Graham, who works as part of the Learning Disability Programme in NHS England. Today they're going to talk to us about what helps make a successful care and treatment review. Okay, so over to you. Thank you.
Hi, it's Maggie here.
Hi, this is Gavin Harding here.
Just to give you an overview of what we're going to talk to you about this afternoon, we're going to tell you a bit about the policy refresh process and some of the themes and feedback that we've had so far with regards to the care and treatment review policy. We are going to talk to you about some work that Inclusion East have been doing for us and with us, which is developing what's called gold standard profiles for people that are involved in a care and treatment review. And Gavin Harding is going to say a little bit about his role and the role of the Learning Disability Advisors with NHS England, and about you know, having a valued paid role and job and what that means to him. And we're going to start with that. So I'll hand you over to Gavin now.
Hi. I'm Gavin Harding, a Learning Disability Advisor within the Learning Disability Programme, and we actually employ people with learning disabilities in the programme, myself and Carl and David Gill. Our roles are to lead on certain projects, and mine's to lead on the care and treatment review policy with Anne Webster and the discharge policy. And Carl leads on medication, the quality life, and looking at complaints and compliance. And David Gill works within the CAMS team. And also, we've also got the engagement team, and they employ Aaron and Katie, and we are looking to start and appoint a family care advisor to start in the new year as well to join the team. But Aaron and Katie are engaged with people do engagement work around NHS England. But we lead on programmes, and we also are involved in our supervisions and appraisals as well. So I just wanted to let you know that role, and we also make information accessible, and lots of changes have happened to adapt our work in NHS England, and we encourage regions to start looking at employing people with learning disabilities and how to include them. If anybody needs any help on that, we've got accessible information on how they employ us in our role.
Thanks, Gavin. So now we're going to hand over to Maggie, and Maggie's going to give you a bit of feedback about the care and treatment review policy refresh.
Yeah, so hopefully many of you will be familiar with the fact that we've recently been asking people for their opinions about the care and treatment reviews, because we are doing a policy review. It's a year since the policy was written. So we sent out some questionnaires over the summer, and the closing date was only just over a week ago, really. So we've had feedback from well over 200 people about the policy. I can't be a bit more specific than that, except that we have been delighted with the amount of feedback that we've received, and we're in the process of analysing that feedback at the moment, and we'll be meeting with the advisory group for the policy review soon to look at what that means. So the idea really is to use all the learning that we've had from the experience of carrying out care and treatment reviews over the last year to look at where the policy needs to be made a bit stronger or where we need to make any changes. We're looking at publishing the revised policy hopefully by the end of January. Before we go on to the work with Inclusion East, I thought people might be interested in knowing a little bit of the feedback we've had. As I say, at the minute it's still being sort of analysed really, but there are a few themes that are emerging. So one theme that's come up quite a lot is to look at the relationship between care and treatment reviews and CPAs, and certainly we've had feedback that CTRs are helping to ginger up the CPA process. We've had confirmation overall, I'd say, that the principles of care and treatment reviews are beneficial for people with autism only, and we'll certainly be looking to strengthen that area of the policy. We've had feedback that people would like more easy-read information. At the moment, that's provided in the form of separate leaflets, but we're looking to try and combine all of that together to make that a bit more streamlined and user-friendly, and also more information for the person who's having the review. And we're also looking at, for example, at including accessible consent forms within that, and also an accessible consent form around what we call the risk of admission register as well. On that particular topic, I think overall the feedback was that that is not really a very user-friendly name, the risk of admission register. So we're looking at some ideas for trying to change that so that it's a less daunting thing for people. Very quickly, other things like the CTR report needs to be clear about who is doing what by when, that we need to be make it clearer what the role of providers is in the CTR process. Lots of feedback and lots of different opinions about the timing of CTRs, when they happen and how long they last, but certainly I think everybody is interested in maintaining the quality, so that's going to take a bit of looking at. Quite a lot of feedback on the role of the chair and who can chair a CTR, and in terms of children and young people, probably the overall feeling that we're getting at the moment is that this is going to need a separate section in the policy. And one of the things that we've noticed is in the feedback is that we asked the question about how often children and young people's CTRs, inpatient CTRs should happen, and there seems to be quite a strong view that once every 6 months might not even be enough for children and young people. And then finally, the other theme is really just about the importance of good preparation for the CTR and making sure that everybody comes to the CTR knowing what their job is, really. At the same time, we've been working with Inclusion East to look at some gold standards around care and treatment reviews, and that's looking at a number of different areas, such as what makes a good care and treatment review chair, and that's what the rest of this presentation is going to focus on. But we're also looking at other things with Inclusion East, such as what makes a good expert by experience, what makes a good clinical expert, and what indeed makes a good care and treatment review. Some of the things that have been highlighted by the work that Inclusion East has been doing around the qualities and credentials. So that really just means what does it take to be a good CTR chair. So the first thing is that the CTR chair is the commissioning lead who has current knowledge of processes. So that's things like understanding contract arrangements and being able to hold the provider to account for delivering what they say they will do, and an understanding of things such as legal frameworks, human rights. The next thing is that the CTR lead should be independent, so somebody who has never worked in or for that provider, and that it's important that the chair should declare any interest if they have any. The other thing about bringing out the skills and knowledge of the people involved is really seeing the CTR as a collaborative process between all members of the panel and ensuring that people are meaningfully involved, are clear about their roles and are supported to carry out their role within the CTR properly. And finally, the CTR chair is able to challenge areas of poor practice when they see it. Okay. So Gavin.
Yeah, it's about supportive of the panel members, and that's making sure all panel members are singing from the same hymn sheet as well, and also having different views and respecting those views as well. And it also making sure that the expert by experience who comes as part of that panel is very much included right from the start, because a lot of people have said they don't feel included at the moment, and this is very vital to make a CTR panel, because we're expecting people to come in who sometimes knows the system and doesn't know the system, and it's important that we make everybody inclusive. And it's also to make sure that that person's support worker, especially when it's a person with learning disabilities, is prepared, and making sure that their whole preparation is done, because that support worker is there to also see and spot if that person's upset by the situation, so that the chair knows when to take breaks and when it's for the panel members. Yep. It's also knowledge about the transforming care and empathy for the person is not a hospital, it is not their home either. And it's about making that hospital setting comfortable as well, but it's also making sure it's not that person's home and we're getting people out. But it's getting people out to the right place as well, because we need to be supporting people so that they don't go back into hospital again. And that's getting the right community setting and the right provider, or looking at direct payments or individualised budgets, and making sure the person knows about the employment laws when we do that. But it's also having an understanding of the person-centred approaches. But when we mean person-centred plans, because a lot of person-centred approaches haven't worked in the past, it's about personalisation to that person's suitable needs. And that's what we need to be looking at, and making sure that person is able to feel they have control of their life, but also to make sure the support worker there is to support people and able to do the things that people are able to do, like we do in life. And it's also making sure there's fallbacks around the tools so that people can go to someone instead of ending up in a crisis going into the hospitals. And we need to know people and understand where people are coming from, and using alternative services in the first voluntary sector as well, and knowing about the contract with the setting. And that's about providers coming into that setting as well, and people able to choose who their provider is and able to be on the interview panel. So that's the correct procedure. Yet, knowing about the initiatives and alternatives to hospitals, this could be through visits and finding out examples of good innovative ideas where people live in the community, and reflects with others to develop their skills as chair. And that means the chair understanding what kind of setting people are going to, and the commissioner feeding that information and going out with a family carer and the person with learning disabilities checking out what's alternatives in the community. And is also prepared to ask and encourage very basic questions and looking at details, looking at CQC reports of that provider, and also making sure the person hasn't come from that provider in the first place and going back into that setting when it could be the provider that is put the person in there in the first place as part of the issue. So I'm just handing you over to Anne.
Thanks, Gavin. Okay, so obviously the role of the chair is a very, very important role in the CTR, and that person needs to have the ability to make sure that everybody's focused on the important reasons that they're there for a care and treatment review. So to make sure that there is a focus on the individual and improving their care and the plans are in place for their current care and their future. They also need to be able to facilitate that, I think Maggie said earlier, that collaborative approach, and having, bringing people together to talk about a shared approach to problem solving. So identifying the barriers and enabling people to be open and work together. And I think sometimes we've talked before about the kind of elephant in the room issue. So some of the issues that are really hard and that might be preventing somebody moving on, actually being able to discuss those and try and address those together and come up with solutions, and enable those topics to be discussed in a constructive way. Chair as well needs to, in terms of making sure that a care and treatment review is carried out well, there's the preparation that needs to go on beforehand, and part of that preparation is making sure that the hospital setting are aware of the information that needs to be pulled together in advance of a care and treatment review, to make sure that when people arrive on the day that you're not having to look through lots and lots of information, but ideally there's a pack there that's ready, and ideally that should be lots of accessible information which would be needed for the individual that they're supporting too. So just making sure things are well organised, making sure that the programme for the day is set at the start of the day, and there's a discussion about how the panel's going to work together, using people's skills and experience, and also thinking about, how's this going to work for the individual and family? At what point in the day are we going to meet with the individual, and where, and who will meet with the family? So really that kind of important planning at the start of the day, and going through and preparing the panel for and people at the CTR for what's going to happen. Also, another important role of the chair is to make sure that the panel members also declare if there's any potential conflict of interest, which might mean that, and that should be done before the day, because if somebody who is a possible clinical expert on a CTR maybe recently has worked in that service or had a relationship with that service, there could be a potential conflict, and that's really important to enable people to do the job they need to do, and challenge that that conflict is declared, and there are times where it might be that the person isn't able to carry on in that role. Visiting the ward, so this is about just getting a sense of where somebody is currently residing. It might be when the individual themselves is being reviewed is met with, that the chair and perhaps another member of the panel are able to see the ward and where that person lives. But it might be just popping in and getting that sense of where that person is receiving their care and treatment is an important part of the care and treatment review.
When a CTR takes place and after the care and treatment review takes place, it arranges to report back to panel members, and that means giving them feedback on about the urgent actions, because there might be something holding up those urgent actions that the panel might need to reallocate to somebody else to do that role and take on those responsibilities. And that includes in the expert by experience, because a family carer or a person with learning disabilities might know where to go to for that service, because they've got knowledge of that and what advocacy services are out there available. So it's very important that you listen to the views of the experts by experience as well. But making sure the next review will use the same expert by experience to maintain consistency, unless there is a reason why it should be someone else. There could be a reason why you need to use someone else, because it could be a report about a safeguarding incident in that care and treatment review. But it's also important that we get the right panel members to pick up on whose expertise in those areas as well, and that's the chair's responsibility to make sure everybody's clear what they're doing. but also pick up on any challenges for the panel members that might need further discussion. And that could be people on Ministry of Justice restriction orders, where you need to know the law and how you could do it, and the recommendations in the time limit to look at that, because sometimes the Ministry of Justice knocks it back for people, and it's learning about that process. So it's quite important that the panel members need further discussions about discharging. Also, takes actions. Gives the person time to take part in the review the way they feel most comfortable. And that's making sure that the person is comfortable coming into the room. Sometimes that might not happen, but also making sure that they're comfortable talking about issues and collecting that paperwork at the end of the day as well. Making sure that the person uses words that everybody can understand. And that is using words and pictures as well. And make sure the report is written in words that everybody can understand and not abbreviations. And making sure that someone is following up on actions as well. Because we don't want people there who are not going to follow up on actions. And that's one of the part of the job of the chair and the commissioner who is there to make sure those actions are carried out, and nursing staff and everybody being involved in taking that away. And make sure that any problems carrying out actions are dealt with quickly, because the longer you take, the longer people are in the assessment and treatment unit, and then that's when the national team come down and say, why hasn't that person been moved quicker?
Just to conclude, can I just say that these gold standard documents are all draft, so part of the reason of talking it through today is also about getting feedback. And as we said, there are a set of these that by the time we publish the policy, we will hope to publish alongside the policy to help people with a CTR.
Okay, now we've still got 6 minutes for people to be able to ask questions. So if anybody does want to actually speak and ask a question, please raise your hand. We've got one question so far in the chat box, which is from Michelle, and she's asking, are the NHS England advisors available to children and young people's CTRs?
Yes, they are, because David works in the CAMS team.
Only David, yeah.
There's only David who works in that CAMS team, but CAMS teams need to employ people regionally if they can as well, and adapt that if that is an issue.
Got a question from Gary Watt, who's asking, is there any training being made available for chairs / clinical reviewers?
Yeah.
So at the moment we're developing and just about to test an e-learning for care and treatment reviews. That's being tested in November with a view to it being published alongside the new policy, because we might have to tweak in line with the new policy too. And we are also considering commissioning some more training being developed, but currently there are a number of more, probably the expert by experience hubs like Inclusion East, Inclusion North, Northwest Training Development Team that do offer training too. But it is an area that we are hoping to do some more work around nationally. And if people are interested in testing, actually in the bulletin that's coming out, I think in the next week, it will talk about the testing of the e-learning and ask if areas are interested in testing to let me know, and we are looking for areas that will kind of bring groups together and pilot the e-learning and give us feedback. So there'll be a questionnaire coming with it. So people can let me know if that's if they'd like to get in their areas to get involved.
Okay, great. Thank you, Anne. We have another question from Anne asking, and what about training for commissioners? Will that be mandatory or just desirable for them?
There is some training being looked at for commissioners, because Joe Pointer is leading on this work in the Local Government Association and leading on a panel looking at training for how many years of experience for commissioners across social and healthcare working in different ways.
Yeah, like Gavin's right. There's a group looking at overall training for commissioners and development support. There's also some work in specialised commissioning looking at particular development for case managers, and there is going to be something in care and treatment reviews, on care and treatment reviews in that package, which I think is sort of February time that's being delivered. The e-learning is also for commissioners, but I think the bit about the role of the chair and the commissioner is likely to be something we will also look at, some particularly sort of commissioning some training to be developed for. So something more, I can't say if it'd be mandatory or not, I'm not sure about that, but certainly it's something that's very important for commissioners.
Okay, great. Thank you, Anne. We've got another question from Susie O'Neill. You were focused on inpatient CTRs. Are you also providing guidance for community CTRs?
Yes.
Yeah, definitely. Yeah.
Yes.
Fabulous. Also, a question from Sarah Marshall. Is consent needed for a blue light CTR?
No, because I think you need to judge on that, and that's a community nurse at the moment. But I think you need to put a care and treatment review community one for blue light in place, because it's about looking at what practical services are around you.
Yeah, can I add, I think this is one of the areas that's caused confusion, having a sort of blue light protocol and a community care and treatment review, and there seems to be a fair bit of confusion, and we're picking that up through the refresh and engagement process. So I think one thing we'll want to do is sort of clarify that in the new policy. And a blue light was always intended to be really what would be going on anyway in terms of best practice and codes of conduct and code of practice of Mental Health Act as well, in terms of looking for least restrictive option and discussing with the person, discussing with the family, the team working together. And it doesn't bring in external independent experts, so that's the difference between that and a CTR, and it's meant to be where there's not, you know, it's something that's meant to be put in place when there's not time to set up a CTR and there's a more urgent situation or a crisis, and it really is about what's good practice and what should be happening already, but it just gives the commissioner some extra questions to ask. So it wouldn't therefore need consent, because you're not bringing in the expert, clinical expert or expert by experience.
Okay, great. Thanks, Anne. We've actually come to the end of the time we've got available at the moment for the questions. I know there are still some questions in the chat box that need to be answered. If Anne and the team don't manage to answer them while we're on the webinar, we will extract them from the chat box and ensure that you received an answer to those questions. So I'd now like to thank Anne, Gavin and Maggie for your excellent presentation, and it is really important for us to know what the role and responsibilities is of the chairs to enable us to have some successful care and treatment reviews. So I'd now like to hand over to Phil Brayshaw, who's from NHS England, who's going to talk to us about guidance for TCPs in relation to children and young people. So thank you, Phil.
Hi, thank you. Good afternoon, everybody. Okay, I will start just by giving a little bit of context. So I think an important point to make at the outset is that Transforming Care has always been an all-age programme. So the policies that we've heard about so far today in terms of the CTR policy and the things that I'll go on to talk about, such as the service model and building the right support, do apply equally to children and young people as they do to adults. And I don't think that's always been as clear as it might have been. Part of why I've been asked to talk today is that we're also looking at what specific support we can give to commissioners in Transforming Care partnerships, specifically around children and young people. So that's what I'm going to be talking about. I thought I'd start right at the beginning because I know this is a diverse audience. And so just to say something about Transforming Care partnerships, which are groups of collaboratives of clinical commissioning groups and local authorities and other partners locally that are looking to transform local services for people with learning disabilities and or autism. And to do that, they've set out plans with clear milestones that go alongside that. And so a key part of that, or a key part of the role for Transforming Care Partnerships, is to look at how they implement building the right support and the service model for people with learning disabilities and or autism. And so if we start with building the right support, there are two ends, and I think this was talked about on the previous part of the webinar. But this is about reducing inpatient beds. It's about closing inpatient facilities, but it's also, and crucially, it's also about improving community services for people locally. And the service model sets out a blueprint for how local commissioners, through Transforming Care Partnerships, can do that against 9 key principles, which is what I'm going to go on and talk about today. There's also a supplementary document for commissioners alongside the service model that explains some of the terminology and explains in a little bit more detail the cohort of Transforming Care and some of what's expected in terms of commissioning intentions. And again, I think it's really important to note that that's an all-age document. That said, some of the feedback was that the service model could be clearer in terms of spelling out commissioning intentions for children's commissioners. And I think, you know, if we think that Transforming Care has come back from, as initially started from the abuse that was seen at Winterbourne View, I think it was appropriate that the programme at that time had a specific adult focus. But I think we now need to look much wider than that and look at how people are becoming adults that are ending up in inpatient care, and whether or not we can put support in childhood to children, young people and their families that can prevent that pathway into services. What we've looked to do is to produce a document which is going to be published mid to late November, depending on Gateway. And as Anne was saying previously, part of this webinar today is to get feedback from a wider group of people around some of the ideas that we're putting into these documents. And that document is going to be a supplement to the service model that specifically looks at children, young people, the family, and their specific needs in relation to the 9 principles. It sets out, first of all, the need for a lead for children and young people in Transforming Care Partnerships. But one of the things that we've noticed when we've looked at the plans that are available from Transforming Care Partnerships is that children and young people's needs are not always well addressed. And so we're asking, first of all, for somebody to take local accountability for including children and young people in plans and subsequent delivery. The next bit that wasn't always obvious in the plans and that we're looking to address through this new supplementary document is building the links between Transforming Care and the work that's already happening locally as part of the SEND reforms, the Special Education Needs and Disability reforms, and the CAMS transformation programme. So we're aware that lots happening around children and young people. And it's a matter of bringing that in and tying that up, because as you'll see as I go through the principles of the service model that apply to children, there are lots of overlaps and lots of links to be made. The next bit that we try to include in this supplementary advice is the legislative framework, because of course a lot of what we're setting out and asking TCPs to consider and implement are legislative requirements, either under the Children's Act, the Children and Families Act, or through SEND guidance. And so it's some things for Transforming Care Partnerships to be aware of. And so we're trying to look at how each principle lines up with legislative requirements, both on CCGs, local authorities, and their partners. And so, again, this document is really to look at how the service model should be implemented from the point of view of children and young people, and what specific commissioning needs there might be. So I keep referring to this as a supplement, but I think it's important that I mention that this is to be read alongside the current service model document. So building right support and service model document are both available through NHS website, which is where this will be published as well. And those documents sit together. So just to refresh people's memory, or as a brief introduction for those who have not seen it, the service model sets out these 9 principles, and these link together, and they are organised around a child, young person and their family. They start with the premise that children and young people and their families have enjoyable interest in life. That's what we're looking to achieve for people, or to support people with. That where people need care and support, it's well planned and organised around them. That people have choice and control about how that care and support is delivered. That when children and people and crucially their families need support, that's available to them in their community, close to where they live. Children and young people have choice about where they live and who they live with, and obviously that relates closely to and I'll come on to talking about out-of-area placement and specialist inpatient facilities. I get good care and support from mainstream health services, so it's making sure it's the first line of service. And although it talks about health service, we need to include education and social care around children as well. But it's essentially about getting good support from mainstream services. When your needs are at a higher level, the expert health and social care support, and again, support from education in terms of children and young people, is there in the community when you need it. But when children and young people look as though they may be getting into trouble or are in trouble, they get specialist support from not only the Youth Justice Service, but from a range of other specialist services. And if there is a need to be admitted to hospital, then it's for a good reason. It's for as short time as possible, as close to home as possible, and discharge is planned from the point of admission. Again, there's a parity there with adults under the CTR policy. So I'll just go through each of the principles, each of the 9 principles, and some of the things that we're saying around what commissioning intentions needs to look like locally. So firstly, when we're talking about people having enjoyable interest in lives, we're talking about people being supported, for children and people being supported by people who have high aspirations for them. So here we're talking about developing training programs that are co-produced with parents and with families to make sure that practitioners across health, social care and education have those high aspirations. So have aspirations that children and young people will live successful lives in their community, that they'll make friends, that they'll live at home, that they'll go to their local school, and that they'll go on to get a job. There's an expectation that children and young people will join in everyday local activities, so that's play group, leisure, before and after school clubs, those types of things. And here there's a need for specialist commissioners to link with colleagues in mainstream commissioning to make sure that those services have reasonable adjustments for this cohort. So again, we're talking about children and young people, and we're talking quite often about children and young people with quite extreme behavioural challenges. So are there reasonable adjustments for mainstream activity, where local areas are looking to make changes to what's available in terms of mainstream activity, then we're asking for clear equality impact assessments that consider the needs of this cohort and changes to those services. We're looking at children and young people attending their local school with the right support, so there's a very clear link here with the SEND reforms, and I'll pick that up again as we go through, but it also talks of the need to include education as partners in the Transforming Care partnership. That's maybe something that's slightly different in terms of children and young people. The next principle, my care and support is well planned. First and foremost, we're looking at asking commissioners to demonstrate a clear understanding of their local population and that population's changing needs. So we're asking commissioners to be aware of children and young people with learning disabilities and or autism, and be aware of those children who may go on to develop challenging behaviour or are displaying challenging behaviour currently. And that's through the dynamic register. We're talking about the need for person-centred approaches, and the need to promote person-centred approaches through in terms of both assessment and planning, and also review in whatever context that is. We're talking about the need for single assessment and planning, whether that's for children and young people who meet the cohort or meet the criteria for education, health and care plans or not. We're saying that in this cohort, so children and young people and or autism with challenging behaviour, including those with challenging behaviour that comes from a mental health need, there should be single assessment and planning, and there should be key working, because the likelihood is that they'll use a number of services. And again, if we think about the links between special educational needs, transforming care, and CAMS transformation, things like person-centred approaches, single assessment and planning, and key working for families are common to each of those programmes of work, and also feature in the legislation around children and young people with high-level needs. The third principle, I have choice and control about my care and support, and Gavin mentioned some of this earlier in the webinar, and this is about really putting people at the centre of their own experience. It's about having clear information of what's available in terms of care and support, and that can be done through the local offer, which again is a requirement of the SEND reforms. It talks about integrated personalised commissioning and personal budgets, and so that's looking beyond the kind of defined groups of children and people in receipt of continuing care or education, health and care plans, and thinking about how individual or personal budgets might be offered to this cohort much more generally. And then there's an ask around independent advocacy. And what we're saying here is that children and young people who are inpatient in hospital should have their rights robustly protected, and we're asking for that to be done through access to independent advocacy. My family and paid staff get the help they need to support me to live in the community. So again, a lot of these things will be in place locally. Other programs will work around some of these. It's the role of the Transforming Care programme to join some of that work together and to think about how they might advance it in terms of this cohort. Clear ask around early support and intervention, to commission what works well. So we're talking about early support programmes, and we're talking about portage. We're talking about evidence-based parenting programs as part of a much wider programme of support. The document talks very clearly around family support, and that's around emotional support and peer support for families by clear commissioning of local peer support organisations, so parent carer forums, but also making sure that we have the practical support that they need, whether that's in terms of communication aids or incontinence aids or having the right equipment, but making sure that those services that support this cohort of children are commissioned to work well. And then there should be a clear offer around specialist short breaks. I have choice about where I live and who I live with. So for children and young people, this is about having a comfortable, well-adapted home. And so here what we're saying is that children who live in a comfortable, well-adapted home are less likely to engage in behaviours that challenge and less likely to put themselves at admission or out of area placement. We're asking that information on housing be available to families with children with learning disabilities and or autism, and also for specialist commissioners to talk to housing about the future housing needs of this population, so that planning and support is done in a timely way. That should be included in transition planning and especially in preparing for adulthood reviews, and that there should be clear provision for children living away from home, and that should include, as a very minimum, knowing who they are and where they are, ensuring that they have education, health and care plans when they need them, and maintaining links with home. Support from mainstream health services. So we talk here about the need for timely diagnosis with concurrent support. So this is the idea of providing care and support alongside any assessment processes, and making sure that diagnosis is at the very least within NICE guidance. So for things like ASD, for example. We talk about the need for hospital passports and clear liaison for children with challenging behaviour. So where a child is known to have challenging behaviour or likely to exhibit challenging behaviour, they should have a hospital passport, and there should be clarity around that. There should be paediatric assessment available to rule out any physical cause of challenging behaviour, and there's a reminder that health checks should be available to children and young people aged 14 plus. And finally, on that principle, there should be early access to flexible specialist support. So here we're very clear that children in this cohort should be a priority within local services and shouldn't be excluded on the basis of rigid eligibility criteria for specialist services. So they're saying where there is a need, children, young people should be able to access support from CAMS or speech and language therapy or youth justice services outside of the usual eligibility criteria. I get expert health and social care support, again, add education to that. So that support should be integrated, community-based and specialist, that specialist staff should support early intervention. So again, that's around that flexibility of service boundaries. That positive behaviour support and other specialist intervention should be commissioned and available locally, but training should be available in IAPT and speech and language therapy, and that there should be flexible support services. So they're calling for pathways to be developed locally that offer a very clear response, specialist response to children and young people who demonstrate behaviours that challenge. There will be some further support, further guidance and a toolkit that accompanies this supplementary document that's been developed by the Challenging Behaviour Foundation and National Development Team for Inclusion, which will support local areas develop those pathways. There are also some national service specifications being produced, which will support the development of those local services. I get help to stay out of trouble with the law if I need it. Essentially, this is around making sure that youth justice services are accessible to people with learning disabilities and or autism in terms of adjusted programs, but also making sure that children and young people who have not been picked up as having particularly milder learning disability or autism without learning disability are picked up in youth justice services and appropriately signposted to additional support within learning disability services or specialist education. And making sure that those children and people have access to a full range of support, including the things that I've talked about previously, such as parenting programs. We talk about the need for youth justice services to offer consultancy, supervision and training to other services, including CAMS and learning disability or intensive support services, and the need for those services to work much more closely together, and the need for a liaison and diversion function. And then finally, there's the final principle that talks about the need for inpatient care. And so essentially here we're referring people to the care and treatment policy and saying, remember that children and young people need a community or pre-admission care and treatment review prior to any admission to specialist hospital. We're saying that where children and people are admitted to hospital, their relationships with family and friends should be supported, whether that's in terms of financial support or help with travel. That there should be a clear rationale for specialist admission or inpatients there, and that should be monitored through the CTR process. Again, we're talking about independent advocacy, which is additional for this cohort. And we're talking as well around governance of out-of-area placement. So it's something I've touched on previously and something that the document goes into more detail with. The need really to think about children who are placed out of area, children and young people, whether they're inpatient or not, or whether they're in 52-week residential placements, to know that population of children and young people are and make sure that there are clear plans in place to deliver support locally wherever that's possible. But to make sure where children and young people are inpatient or placed out of area, residential schools or similar, that there is access to family support, to independent advocacy, to clear review, and that there are expectations that those placements will be the least restrictive and as close to home as possible. And so it's about making sure that there's governance around that. So that is a very quick oversight of what the supplement will be, the types of things really that the supplementary document is going to be talking about. And there are lots and lots of asks there for local commissioning organisations. The document is very clear that this isn't about considering what needs to happen locally. It's about putting these things into place. I've introduced this. The document is clearer, I guess, in terms of giving some examples of what things might look like locally or where you might go for advice and support. And then there'll be a further offer of support to transforming care partnerships from the national delivery team to look at which parts of this might be difficult to implement and might need either additional funding or funding identified from elsewhere or some additional support to implement. And so I guess I'm preempting some of what's next, which is the space that we've left for questions.
Okay, thank you very much, Phil. It was really interesting to hear about how the 9 principles of the service model do particularly relate to the children and young people. We've got a few questions in the chat box. We've got about 4 minutes left. Go to the question from Claire Staley, which is, would the assessment framework offer a wider perspective and be used in conjunction with the service model?
Well, I guess we'd be talking here about the local assessment frameworks. The assessment frameworks that are currently used, I'm assuming that would be the case. And in terms of common assessment framework, in which case I would say yes. So the kind of two things fit together. I think the other thing though to mention as well, which I've forgotten to mention, is that there's a further. We're publishing this in terms of the document, so the ask will be in the supplement document. Alongside that, there will be an audit tool that helps local areas think about where they are currently in the planning and delivery of each of these parts. So there is an audit tool that sits alongside it. I'm not sure without being clear of what the question is. I to answer that better really.
Got Anne Worrell Davis' question: are EHC education healthcare plans going to be flagged up in the children and young people supplementary document or elsewhere? As in my experience, EHC plans seem to be one area that is missed very often by providers stroke settings, and we so often have to put as an action in CTR reports.
Right, that's an interesting question and quite an easy one, because yes, they're mentioned all the way through, and so there's a very clear requirement for children eligible for education, health and care plans that plan becomes central to their care and support, and where children are not eligible. What we've specified for this cohort is that they should have a parallel process that looks very similar based on person-centred approaches and brings together each of the organisations in terms of what they could and should be offering. And so, yes, the document asks for clear governance around health, education and care plans in terms of each organisation meeting the statutory timescale, but also in terms of quality of content. I think we go as far to ask that CCGs have a process for sign-off of education care plans for children in this cohort. That's very quick, but I think is the answer.
Okay, thanks, Phil. So we've run out of time, unfortunately, to answer any more questions live, but we will, as I said, address all those and send out the responses with the recording and the slides to today's webinar. Just quickly to say that thank you for everybody for attending. Thank you for our speakers for your excellent contributions. And just to mention that next month the webinar will be focusing on strategic resettlement, personalisation at scale and pace, and also we'll be hearing from Worcestershire, who will be reflecting on some good practice around avoiding hospital admission, where they've developed an enhanced care service. So once again, thank you very much, everybody, and I look forward to welcoming you next month.